Bismillah ar-Rahman ar-Rahim. Good evening, everyone. Welcome all of you for the third session of UAE chapter of headache. We had many interesting cases in the past, and we continue to promise you more interesting topics and cases. Without any further delay, I welcome Dr. Areen Said for his first session. Dr. Areen is known to everyone. He's a consultant neurologist in American Hospital of Dubai. He is expert in many topics in neurology, including headache as well. He is presenting today on real-world evidence of anti-CGRPs. Dr. Areen, the floor is yours.
Thank you all for attending this program. To thank also Dr. Abubaker Al Madani for chairing this session, and also to thank both Novartis and MCO for inviting me, sponsoring, and also organizing this event. Today, we will focus on understanding and mapping out the progress of real-world evidence in migraine prevention using Hironumab and other CGRPs targeting the CGRP pathways. We know that globally, 1 in 10 people suffer from migraine. The international or global incidence of chronic migraine ranges for chronic migraine is about 6.8%, and for high-frequency episodic migraine is about 8%. And although we have very effective and safe therapies with the new CGRP-related monoclonal antibodies, but in general, less than 2% of eligible populations are currently on these monoclonal antibodies, and only 0.5% of patients who are eligible are on Erenima or Aimovig. We know also from previous data, and particularly the American Migraine Prevalence and Prevention Trial, that only 12% of patients who were screened or surveyed were actually on prophylactic medication, and only 26% of those who have migraine headaches were actually offered prophylactic medication in this study published back in 2007. Now, we know from the randomized clinical trials the effect and efficacy and safety of these monoclonal antibodies. But when it comes to real-world evidence and real-world data, what type of information is being published these days? This is looking at the most recent data going to early part of this year. Now, these trials usually will evaluate the effectiveness of these monoclonal antibodies. Some of them can look at safety and tolerability, the patient subpopulation, including episodic migraine and chronic migraines. Sometimes they look at patients with medication overuse headache. They also can look at the dose and route of administration of these medications. Many publications have been already published in literature, many in Europe and North America. And we have actually 2 studies by our colleagues in UAE, one single center study, and one was multi-center study. We will touch base on these 2 studies also from UAE in the context of our presentation. Why and what is real-world evidence? Real-world evidence is the clinical evidence regarding the use and potential benefits and risk of medical product derived from analysis of real-world data. So essentially, these are phase 4 trials after the drug has been approved. And while the randomized clinical trials assess the medical product in highly selective patient population and in tightly controlled setting, where patients need to meet certain and stringent inclusion and exclusion criteria, real-world evidence data assess the medical product in more clinically diverse setting and patient groups. It also assesses the medical product under conditions that reflect the used treatments in actual clinical practice. Additionally, the randomized clinical trials evaluate the treatment effect within a specific time frame. Rarely these patients can go up to 2 or 4 years. Very rarely in some longitudinal trials, they may go to 5 years or so. However, in phase 4 trials or real-world evidence trials, they can evaluate those patients for a long-term duration, and they can evaluate the safety, the quality, and any barriers to use of these drugs. So the real-world evidence trials are complementary to the randomized clinical trials. They can help supplement and complement the original phase 3 trials. Now, when we evaluate real-world data, we look at probably many factors, as we mentioned, including the effectiveness of the drug. Does it persist over the course of the years? Is there any safety or tolerability concerns? We will go just through some selective trials to reflect these 3 items: the effectiveness, the tolerability, and the persistence. This is the early study. It recruited 372 patients in Italy. These patients who were recruited are patients who have high frequency episodic migraine. These are patients who have more than 8 migraine days and less than 15 migraine days in a month, and chronic migraine patients. And they treated those patients and followed them for 3 months. And the patients who were enrolled in the study were those patients who actually failed 3 or more preventative medications in the past. And certainly, after 12 weeks of observation, almost 60% of patients with high frequency episodic migraine and about 55% of patients with a chronic migraine had more than 50% reduction of their monthly headache days. This is another interesting study that looked at the dechronification from patients who have chronic migraine, and they enrolled patients at baseline who all of them had chronic migraines, and they followed them up for 6 months. And these patients received Hironumab treatment and at least 6 months follow-up. And interestingly enough, after 1 month of the treatment, almost 50% of patients who had chronic migraine at baseline converted into episodic migraine. And if you actually look at the last 3 months of the study, almost 69% of the patients are converted into episodic migraine from chronic migraine. So we have data that replicate the phase 3 trials in many of these real-world evidence. So another question that comes out: what to do for patients who have been not responding to more than 4 previous preventative therapy, i.e. those patients who have highly therapy refractory patients. We know that many of these patients were not enrolled in the original trials. This study is from Germany. The study included 100 patients. 74 of these, or almost 3/4 of the patients, were patients with a chronic migraine, and 26 were patients with episodic migraine. Out of those 74 patients with chronic migraines, 66% of patients were also patients with medication overuse headache. In summary, at 3 months, 41% of patients with a chronic migraine and 58% of episodic migraine had more than 50% reduction in their monthly migraine days. And almost half of the patients converted from chronic migraine into episodic migraine. At the end of the follow-up period, almost 47% of the patients were no longer having medication overuse headache. I can refer you also to these 2 publications regarding the effect of Erenima in patients who failed or had partial response to botulinum toxin. Again, many of these patients were excluded in the original trials, and so there is evidence that these patients may respond to monoclonal antibodies targeting the CGRP pathway if they have not been well responders in the past to Botox. The other thing we need to talk about here is does the real world data also confirm the safety and tolerability of the CGRP monoclonal antibodies similar to the phase 3 trials? Is there any new safety signals being noted? And one question becomes, is this data persistently effective for patients who are receiving monoclonal antibodies targeting the CGRP? This looked at patients in Canada. Almost 15,000 or 14,000 patients were looked at retrospectively. 83% of the patients were female, 17% were men. Median age was 47, and almost two-thirds of the patients with chronic migraines. Almost 71% of these patients, after 1 year, were on treatment. This is in comparison to the data we know that actually only 11% of patients who were previously on standard therapy, including antidepressants or antiepileptics or beta blockers, remain on therapy after 6 months. So significant adherence to the treatment with these new monoclonal antibodies compared to the standard therapy that used to be a few years ago. The question becomes also, when do we stop these molecules? Should we stop these molecules? Should we challenge the patient of these anti-CGRP? A couple of the trials, this trial actually is from Switzerland, Dr. Kantenbein. They enrolled 52 patients in this study. These were patients who had episodic migraine or chronic migraine. They were treated with Hironumab and other monoclonal antibodies for 12 months, and they collected the data from 5 centers. Those patients with episodic migraine had almost 14 plus 7 monthly migraine days, and those with the chronic migraines have a baseline of 20 days per month. If you look at their treatment response while on therapy at 3 months or 12 months, you can see that their monthly migraine days dropped from 14 to 6 and 5 respectively in the episodic migraine, and it dropped from 20 headache days to 7 and 5 in the chronic migraine days. However, when the medication was stopped and those patients were challenged of the Hironumab, you can observe that there is increase in their monthly migraine days at month 1, 2, and 3 after a treatment interruption. Although it didn't go back to the baseline, but there was a trend to increase of their migraine headache days. And then after they restarted the treatment after 3 months, the headache frequency dropped back again, relatively close to what they were during the treatment in the first year. Again, there's other studies that looked at patients with a chronic migraine with medication overuse headache and their evolution after treatment cessation. These are patients who were enrolled in the study and had been on the treatment for 1 year. Only patients with a chronic migraine and medication overuse headache at baseline were enrolled in the study. And then treatment was interrupted or stopped after 1 year for 3 months. And they looked at those patients and what happened to them and how many of them converted. So if you look at the end of the first year, only 15% of the patients were chronic migraine with medication overuse headache at the end of the treatment. However, after 3 months, that percentage increased to 35%. And these 35% were chronic migraine, and they were back on their medication, analgesics, and they were using them more than 10 or 15 days as per the definition. Also, the monthly migraine days increased from 12 to 18 days after 3 months of suspending their treatment. Now, do we have local data in the UAE with the use of Hironumab? There is a good, I think, soon to be published paper by our colleagues, Dr. Tawfiq Saadi, our chairman, Dr. Abubaker Al Madani, and Dr. Suzanne Nouri also, from 3 states, Sharjah, Dubai, and Abu Dhabi. This was a retrospective review of about 166 patients. Patients were either on 70 or 140 milligram Erenima, and these were patients who were followed for at least 6 months, or at least they had data on them for at least 6 months after a treatment. About 57% of the patients were episodic migraine, and 43 patients were chronic migraine, including patients with medication overuse headache. The key findings that, which is very interesting, it's different than some of the other global data. 87% and 62% of patients had more than 50 and 75% reduction in their monthly migraine days. And interestingly, upon chronic migraine patients, it was actually reported that 95% of the patients achieved more than 50% reduction in their monthly migraine days. Probably this is the highest I have seen between local and global studies. Also, the total number of migraine days dropped significantly from almost 18 days down to 8 days. And this study again confirmed the efficacy and safety of Hironumab in the real world setting. This is just a graph of the similar information we have shared earlier, that up to 95% of patients, particularly the chronic migraine patient, achieved more than 50% reduction in monthly migraine days at 6 months. And this is the 75% response and reduction of monthly migraine days at 6 months. For chronic migraines was 72%, and for episodic migraine was 54%. This is another trial by our colleagues at City Hospital. They had 91 patients data that they looked at retrospectively. These patients were also receiving either 70 or 140 milligram during 6 months assessment. And this is more of the patients in this trial was chronic migraine patients with medication or without medication overuse headache. And again, a significant percentage of patients, overall 80% of the patients achieved more than 50% reduction in their migraine days, and more than 69% achieved more than 75% reduction in their monthly migraine days at month 6. Similar data was also for the 50% response after 6 months. And again, there was no safety concerns during the study. And it just reflects again the long-term efficacy of Hironumab in this group of patients. Coming to the most recently published Hermes study, which is the first head-to-head study of Hironumab against topiramate in patients who have migraine, to assess the tolerability and efficacy in a patient-centered setting. Now, we have seen from previous trials or previous data that patients on oral therapies for different reasons, including side effects, after 6 months, only 10% of the patients are on these therapies. Although some of the available data here have shown that patients have more adherence to these monoclonal antibodies. So why do we need to start patients on all drugs? Although we know that the adherence and the tolerability of the new medications are higher with these monoclonal antibodies. So this study, again, was a head-to-head study comparing topiramate and Hironumab, and it was designed to assess the efficacy and safety of these drugs. It was a study in Germany where 82 centers have recruited about 780 patients with episodic and chronic migraine patients. It was a 6-month trial and started in February 2019 and continued through July 2020. The primary objective was to assess the tolerability and safety of these two products. And then the secondary endpoints was to look at the efficacy by looking at 50% reduction of monthly migraine days over the last 3 months, month 4, 5, and 6, and some exploratory objectives like some patient-reported outcomes and the reduction of migraine medication headache over the last 3 months of the trial. So this was a double-blind, double-dummy, active comparator study where patients were screened for 2 weeks, and then there was a baseline for 4 weeks. Actually, the 4 weeks of baseline was intended to count the migraine headache days and to be sure that the patients who are enrolled in the study are able to document their headache diary. I should mention that the study originally was recruiting only episodic migraine. But when about 43% of the patients were enrolled in the trial, there was an amendment to the protocol, and chronic migraine patients were allowed to be recruited. So these patients would receive Hironumab 70 or 140 milligram monthly, plus placebo oral drugs, and the other patients would receive topiramate. And topiramate was titrated during the study. They were followed up for 24 weeks, and then some patients elected to go into the open-label long-term study, which we don't have data about as of now. And patient may have opted to end the study, so they went into a 4-week safety follow-up. 85% or so of the recruited patients were women, 14% were men. Almost half the patients received the active Hironumab treatment and half received the topiramate treatment. The patients were stratified into either moderate frequency episodic migraine versus high frequency episodic migraine and chronic migraine patients. And they have variable disease duration. And the mean was about 10 days of headache days. Again, they were stratified based on the number of headache days, and also 60% of the patients who were enrolled in this trial have been naive and have never been treated with any prophylactic therapy before. Some patients were failure to one drug or two. Few of them were patients who had failed 3 drugs, and the patients who were enrolled were patients who have been on either beta blockers, amitriptyline, or flunitrazine. As we said, the primary objective was to look at tolerability. Only 10% on the Hironumab trial after 6 months discontinued the treatment, compared to 38.9% of patients who were on the topiramate arm. So almost 4 times more patients discontinued treatment with topiramate due to adverse event compared to Hironumab. Most of these adverse events were really related to fatigue, disturbance of attention, nausea, and dizziness. If you look at the number of patients who have discontinued Hironumab, it's about 10 or 11%, which is really higher than what we have seen in the phase 3 trials, and it could be related to multiple factors. Now, looking at the secondary endpoint, almost 56% of patients who received Hironumab had more than 50% response by reduction of their headache days by more than 50% compared to the topiramate arm, where only 31% achieved the 50% response rate compared to the Hironumab arm. That gives an odds ratio of about 3, given that patients who were receiving Hironumab had almost 3 times more likely to reduce their monthly migraine days by 50% or more. Again, when they looked at some of the exploratory endpoints, just looking at the headache impact test score, there was significant difference between the two groups, where patients who were receiving Hironumab reported significantly larger reduction in their scores versus topiramate. In summary, there were about 41 adverse events leading to treatment discontinuation on Hironumab, compared to 151 adverse events leading to treatment discontinuation on topiramate. A patient may have more than one adverse event that may lead to treatment discontinuation. So this is not the total number of patients. There were reported 1 serious adverse event and 2 serious adverse events on Hironumab and topiramate, respectively. Unfortunately, I tried to find what are these serious adverse events, but I could not. It's not in the publication, and I did not have access to the appendix of the publication. In summary, Hironumab demonstrated a good safety profile similar to the previous studies. There was no new safety events observed in the Hermes study. Treatment with Hironumab demonstrated superior tolerability profile and a higher efficacy compared to topiramate. The Hermes study supports the potential use of Hironumab to overcome the low adherence in clinical practice observed with oral preventative medication, as has been alluded to, and also to decrease the burden of migraine and improve quality of life in broad migraine population.
Thank you very much, Dr. Areen. Very interesting topic. The next speaker will be Dr. Rody El Nawar, specialist neurologist in Specialized Rehabilitation Hospital. He's going to present us on challenging migraine cases. Dr. Rody, the floor is yours.
Yeah, please. So first, good evening for everybody. I would like to say thank you for Novartis, Dr. Abubaker, and MCO to invite me for this presentation. So I hope everybody will like those cases that are my cases in the clinic. And I'm going to start by asking the audience, if possible, to answer me for this question. What's your current level of patient care? So can I ask, please, Ms. Shazad to, yeah. So let's give 10 seconds. Okay, so if I'm seeing that the percentage, mainly our audience are physicians, nurses, and healthcare people. So thank you for your answer. So let me start by my first case that I had in my clinic. And usually I refer always to my patients what they are telling us in the clinic. And this patient specifically told me once he entered the clinic, my clinic, doctor, give me treatment or take my migraine. So honestly, when he told me like this, I felt honestly that I'm under pressure because really this guy, it seems that he has a severe headache. So the case was a 47-year-old male patient known to have asthma and recurrent kidney stones. He presented to me for severe headache. His headache usually started even 20 years ago, intermittent. The quality was like pulsatile, duration usually from 6 to 24 hours each episode. And he mentioned to me that usually per month he had like 4 episodes of headache. So 2 of them were very severe, and 2 others moderate to severe. His headache was accompanied by photophobia and sonophobia, nausea, and sometimes vomiting. And usually he's complaining of neck pain, and his headache was aggravated by stress and exertion. And no, honestly, he told me he didn't get any trauma or head trauma. His pain was relieved by ibuprofen 4 taps per day once he had the headache. So his vital signs were normal for a patient complaining of headache with a blood pressure of 136/70, pulse 80 beats per minute, and temperature was normal. His general exam was normal, neurological exam also normal. And I asked for fundus exam, also it was normal. So when I asked him also, what are the other symptoms that you complain when you have headache? So he told me, usually I see this kind of image, kind of blurry on the peripheral sides of my visual field. So I showed him this picture. He told me exactly this is what he's complaining. So I understood that it was mainly migraine with aura, episodic, 4 days of headache per month. I asked him more about the MIDAS questionnaire, that is a questionnaire to measure the impact of headache on the life of the patient that is complaining of headache. It's very interesting assessment, and it contains 5 questions. Usually it reflects how many days the patient during the last 3 months before his visit, he's complaining of headache that is affecting his life, his social life, his family life. And this patient, after asking him the 5 questions, he got a score of 22. Usually this score, we evaluate the 5 questions, we score them, and we look a little bit how much the headache is impacting the life of the patient. And he was in the severe disability. Just I would like to mention that also in this questionnaire, we have 2 other questions, which is A and B, that usually are not included in the score, but it reflects a little bit how much the headache severity and how many headache days per month the patient is complaining. So the patient was really in severe disability because of his migraine. The patient is a police officer working at night with night shifts. He's married, 4 kids, non-smoker. He's taking albuterol as needed when he has asthma attack. He mentioned to me that once he has the severe headache, he's going to the emergency. It means he's consulting like 1 to 2 times per month the emergency department for his headache. All his lab tests were normal, and he showed me an MRI brain that was done 2 months ago that I would like to share with you the images. So I will start by the infratentorial area of his MRI brain on the flare sequence. So if I'm continuing a little bit to see a little bit the temporal lobes, then getting the supratentorial area, nothing specifically special other than those a few small white matter, white points that usually, if everybody is agreeing with me, we're seeing in mainly all chronic patients, those white matter. Usually they are not specific, very far from the myelinating disease. And so I concluded that the MRI was normal. So I concluded that the patient has episodic migraine with aura. So let's speak about the classification of migraine, especially the episodic migraine. So migraine without aura are usually classified in the ICHD-3 diagnostic criteria and the International Classification of Headache Disorders as a migraine or headache, at least 5 attacks, fulfilling the following criteria. So first, the headache attack should last at least 4 to 72 hours. At the same time, headache has at least 2 of the following characteristics, which are unilateral location, pulsating quality, moderate or severe pain intensity, and aggravated by exertion. If you agree that most of our patients complaining of migraine, mainly they had the 4 criteria sometimes. So during headache, at least one of the following, nausea and or vomiting, and photophobia and phonophobia. And of course, the headache is not due to caused by any lesion or other cause. If we're going a little bit to the right side of this slide and we're looking to the migraine with aura, with typical aura, usually it's a headache typically of migraine, but it contains also one or more of the following fully reversible aura symptoms, which are visual, sensory, speech and or language, motor, brainstem, or retinal. The most common one is honestly the visual, and this is what I'm seeing mainly in my clinic, the visual aura, especially the scintillating scotoma. See at least 3 of the following 6 characteristics, at least one aura symptom spread gradually over 5 minutes, 2 or more aura symptoms occur in succession. Usually the symptoms last 5 to 60 minutes, or at least one aura symptom is unilateral, at least one aura symptom is positive. And here I would like just to mention that sometimes when the symptom is positive or a positive symptom, we should be careful that it's not, for example, a focal seizure. So it's one of the differential diagnoses. The aura is accompanied or followed within 60 minutes by headache. Some cases, the aura is isolated and it's not followed by headache. And sometimes in other patients, the aura is occurred at the same time of headache or preceding the headache. And of course, no other cause for the headache. So this is one of my best slides for migraine. And I would like to a little bit clarify that migraine is constituted of different phases. So for example, patient, of course, he will tell us that he had headache, which is typical as the classification. But I would like to mention that this headache is preceded sometimes by days of headache, by other symptoms, such as repetitive yawning, food cravings, neck stiffness and pain, fatigue. And the next step is, or next phase is the aura. Then one of the most important also phase of migraine is the postdromal phase, which usually is present in 70% of patients. This phase contains the repetitive yawning, food cravings, neck stiffness and pain and fatigue, and it can last a few hours to a few days. So as you see that migraine is not just headache or severe headache. It's sometimes preceded by many days and post-headache many days of other symptoms that can create disability to the patient and impacting his social life. So my second question will be for the audience. For my patient, do you start amitriptyline and do you increase it to 50 milligrams per day? Number 2, do you add propranolol as preventive treatment for his 4 days of headache? Do you start Erenima 70 milligrams once per month for 4 days headache? Do you start topiramate 25 milligrams and then do you increase the dose? Or do you give just zolmitriptan 2.5 milligrams on pain? Because as he mentioned, he had 4 days headache per month. So please, I would like the IT, if it's possible, to put for us the answers. So we're gonna give like 10 seconds for our big number of participants to vote for which treatment. Okay, so thank you for your answers. If I would like to share with you a little bit the answers, I'm seeing exactly around 20% for each answer. So I'm so amazed by these answers because each one of our participants has its own point of view of treatment for migraine. The most one was add propranolol as preventive treatment. So I will stop here and okay. So I would like to change a little bit your opinion about the management of this case. I asked the patient to do something called headache diary. I didn't choose for him any treatment. I told him, look, I would like you please for 3 months to make for me a headache diary and mentioning for me how many days per month do you have headache? And how many days do you feel yourself having also other symptoms? And I gave him 2 headache diary. So the first one, he showed me that in October 2021, he got 4 days headache. 2 of them were severe to moderate, November 4 and December 5. And I was surprised by the other headache diary that when he mentioned that other symptoms such as neck pain, fatigue, mood problem, dizziness, tender scalp, and loss of appetite. And the 4 number or the 4 days became 10. In October, 4, 8, and in December, he complained of 14 days of symptoms due to his migraine. So when to start for a patient a preventive therapy? Honestly, I didn't find in the literature a very clear guideline for this issue. And how many patients of migraine are coming to our clinic? And each patient is different than the other. And how to convince the patient that what's the best treatment for him or for her. So usually what I found that mainly the most expert of headache are prescribing preventive therapy for 2 severe or disabling or 4 less disabling migraine attacks per month. Acute migraine treatment is ineffective or contraindicated. Medication overuse headache is present. Patient preference and highly disabling migraine attacks such as hemiplegic migraine or migraine with brainstem aura. So if I'm asking you again the same question that I asked you before, and what treatment do you prefer for this patient? So please, I would like Ms. Shaza, yeah, please. So I'm seeing a little bit the percentage. Thank you for the answers. So I'm seeing that at least I convinced a part of the audience that they changed their answers and they went more for preventive treatment. So I'm seeing that most of the participants will add propranolol as preventive treatment or start Erenima 70 milligram once per month. So thank you for the answers. So I would like just to explain a little bit how I thought for this patient. So first, if I want to add amitriptyline or start amitriptyline, the patient is a police officer with night shift. So, and usually you know that amitriptyline can induce somnolence. So it's not the perfect treatment for a patient with night shift. Propranolol, the patient is asthmatic. So usually it's contraindicated. Erenima, I will keep it to the end. So start topiramate, he has already kidney stones history. So usually topiramate can also has a risk to induce kidney stones. Zolmitriptan 2.5 milligram for more than 10 days can induce medication overuse headache. So honestly, I start the patient, I explain to him that mainly the most treatment or preventive therapy, some of them are contraindicated and some of them are not required in his or advisable in his case. So I start the patient on Erenumab. As you know, Erenumab and target therapy at the moment in our clinic as neurologists or other doctors, so he's the joker treatment. We can use it, I feel, when we are really in trouble with the patient. And as you remember the patient, he told me that he needs a treatment. So once I started the Erenumab in January 3, so I remarked that the following 3 months, the patient really decreased his number of headache and other symptoms by 1 or 2 days per month. So just for the remark that in April, he got 1 and 2 days of headache, because usually, as you know, the half-life time for Erenumab is 21 to 23 days. So usually after 28 days, I feel that in my experience with Erenumab over 70, 80 patients in my clinic, I feel that at the end of 30 days, some patients are telling me that they feel a little bit the recurrence of headache before their next injection. So for me, it was a very successful result by starting the Erenumab. If after 6 months, I asked the patient again the MIDAS questionnaire, and I was surprised by a total number of 1. That was in severe disability before, the headache became little or no disability for the patient. And the number of headache days decreased to 4 days over the 3 months, and the severity decreased to 3/10 from before 9/10. So this is for my first case that I would like to share with you. The second case discussion, this patient, what she told me when she came to me, and I remember very well that she told me, my pain changed my life. I'm forced to deal with it. I want to be sure I'm coming to get the right medication. And she continued by telling me, doctor, don't waste my time by really giving me treatment that I already took and didn't work with my very resistant headache. So let me share with you this patient case that she's 63 years old, female patient, known to have also asthma, presenting typical migraine without aura. So monthly headache days were 20 to 25 days per month. Very severe. Most of them were 9/10. And she tried amitriptyline. She tried topiramate. She stopped topiramate because she felt, as she said, that she felt like zombie, because as you know, topiramate sometimes can decrease the cognition of the patient. So she stopped also topiramate for side effect. She started duloxetine 30 milligram twice per day for 1 year. She stopped after 1 year because she felt that she was not completely satisfied by the medication. One of our colleagues before gave her also gabapentin 400 milligram 3 times per day for 3 months. She stopped it because she felt a little bit that she was dizzy and she was somnolent a little bit. So now she's on daily paracetamol and ibuprofen consumption, daily paracetamol and ibuprofen. She tried 1 month ago botulinum toxin injection. She told me that she improved partially for 2-3 weeks, and then the headache came again. Her physical exam was normal. MRI and MRV brain were also normal. Laboratory workup was normal, and also fundus exam was normal. So honestly, I felt what I should manage this case. Really, she tried everything. So I didn't have too much choices for this case. When I asked her MIDAS score, that what I explained before in the previous slides, that to measure the impact of her headache on her daily life, it was 48. It means very severe disability due to her headache. 70 days of headache during the previous 3 months, and 8/10 severity for her headache. So usually as diagnosis, it was clear for me that the patient has a chronic migraine. What is the definition of chronic migraine in the international classification of headache disorders? It's a headache that it's more than 15 days per month for 3 months, fulfilling the criteria B and C that usually are typical for migraine without and with aura. And more than 8 days per month should be migraine type headache, and the other can be even tension type like headache. So some of them can be without aura, some others with aura, and usually, of course, patient doesn't have any lesions or any other cause of headache. So at the same time, I explained to the patient by taking daily ibuprofen and paracetamol more than 3 months. Usually we have also an entity called medication overuse headache that usually in the classification of headache, it's a headache occurring on more than 15 days per month in a patient with a pre-existing headache disorder. Regular overuse for more than 3 months of one or more drugs that can be taken for acute and or symptomatic treatment of headache. And of course, no other lesions that explain to us her headache. So the question for the audience and for the participants, what is your plan in this difficult case? So please, I would like to ask the IT or Ms. Shazat to put for us the answers, please. So the first choice was to give the patient prednisone 1 milligram per kilo for 7 days, or physiotherapy trigger points release, or zolmitriptan 2.5 milligram on pain plus venlafaxine, because the patient was a little bit also complaining of symptoms of depression. Another injection.
Sorry, doctor, you have 5 minutes.
Yeah, okay. So another injection of botulinum toxin or CGRP monoclonal antibodies. So thank you for the answer. And I'm seeing that most of the audience didn't choose to inject the patient again another botulinum toxin. And I'm agreeing, of course, of these answers. 18% will start her on CGRP, 22% will give prednisone, and the most of the audience will prescribe physiotherapy and trigger points release. So those were the percentage of the audience. So usually as you know, I started her on Erenima 70 milligram, and I was also surprised by the good results of the medication by decreasing dramatically the number of days per month of headache. For the MIDAS score, after 6 months, it decreased to 4, which is little or no disability for this patient. So I would like to share quickly a very nice study published by Dr. Stewart and his colleagues about the demographic and about Hironumab in chronic migraine with medication overuse. They took 600 plus patients and they analyzed those patients, how many medications, how many number of medication or painkillers. And I will go directly to the result. The patients that were introduced for them Erenima 70 and 140 milligram, they had a very good result, especially in patients that were complaining of chronic migraine without medication overuse, at the same time for patients with chronic migraine and medication overuse. So the results were statistically significant, and they concluded that Erenumab reduced migraine frequency and acute migraine-specific medication treatment days in patients with chronic migraine and medication overuse, improving disability and quality of life. Patients that were on one medication and the 3 medications or combination of therapy, all of them improved by more than 60% after starting them on Erenumab. So the last questions of this presentation, how many months are you suggesting to give her the medication? So I would like please to ask the audience, if possible, to reply to this question. So, okay, thank you for the answer. So I'm seeing that most of the audience will give the patient just 3 months Erenimab, and the second best or the highest percentage was 6 months or once pain is completely resolved. So honestly, it's a very difficult question for us as neurologists when we start Erenimab or other treatment for migraine, how many months we're gonna give the treatment. So I would like just to share very quickly this trial about Erenimab and analyzing the long-term efficacy and safety of Erenimab done by the Professor Masoud Ashina for 5 years. That this trial or this study was an open label treatment phase that some of the patients got 70 or 140 milligram over 5 years. I will go directly to the endpoints. They analyzed mainly the monthly migraine days and how many patients achieved more than 50 to 75 or 100% reduction of their baseline in monthly migraine days. And of course, the impact of headache on the patients and side effects. So as you see that 71% got more than 50% response, 47 more than 75%, and 35% of the patients got more than 100%. And as you see, the result and the benefit of Erenimab was sustained over the 5 years. So I will go also for the impact of the headache on their life. Usually also it decreased by more than 5 points in 73% of the patients in the study. For the side effect, usually it was very rare, but the most common one was 7% for constipation. Very rare cases got any major side effect. So the conclusion of the study was, and it's our last slide, long-term Erenimab treatment up to 5 years demonstrated sustained efficacy, including reductions in migraine frequency and monthly acute migraine specific medication use. No new safety signals were detected in Erenimab treated patients over the 5-year extended treatment period. And these findings support the long-term use of Erenimab for migraine prevention in patients with episodic migraine. And thank you for your participation.
Thank you very much, Dr. Rody, for your very interesting, challenging cases. We reached approximately 2,100 audience, so that's a big record number. So let's go ahead with questions. Some of the questions were really answered in the talk itself, so I'm not going to repeat it. Effectiveness or efficacy of and safety of Hironumab in pediatric population, Dr. Areen.
I don't have that regarding the.
I think the efficacy was not studied in pediatric population. Dr. Rody, do you agree?
Yeah, it's still contraindicated at the moment for people below 18 years old, just because we still we don't have too much studies about this category of patients.
Okay. Someone said, I heard that migraine could be related to food. Is this right? Dr. Areen?
I mean, yeah, we know that some people with migraine can have certain triggers, and food is one of the triggers. And some of the common foods that may trigger migraine when I talk to my patients are the cheddar cheese, you know, the cheese that they put on the pizza, sweeteners, monosodium glutamate, very common in the Thai, Japanese, Chinese dressing. These are the frequent food triggers for migraine.
Thanks, Dr. Areen. I have an interesting question here asked by some of the doctors. Hironumab is expensive and has more side effects. Why should not choose less expensive treatments?
You would like me to answer?
Dr. Rody?
Rody?
Yeah. Yes, so usually I have experience in Erenimab around 70 patients. Usually I'm always asking the patient what he prefers, what's his job, what's the side effect that he's scared, and especially the patient's social or like work and jobs and family. So usually some patients, when they start any other medication, the main level A preventive treatment, sometimes they have side effect also. So, and now due to the Hermes study that Dr. Areen also showed us, we are more encouraging patients to start on Erenima than, for example, topiramate or other treatment due to more effective result and less side effects. So mainly my patients are deciding with me which treatment. So I don't oblige them, but I advise them.
Can Erenima be given to dialysis patients?
Honestly, I don't have any dialytic patient. Yeah.
Good question. I also don't have that about.
To my knowledge, there is no contraindication. If you see the leaflet, of course, Novartis can intervene, but to my knowledge, that's fine. I mean, at least it's given once a month, so you don't have to give it during dialysis, because dialysis can maximum be given 3 times a week. So if you're worried, don't give it during dialysis. Is Hironumab given alone or can be given in association with other medication? Dr. Rody?
Yeah, one study showed that botulinum toxin and Erenimab can have synergistic effect. And usually it's recommended to not stop any preventive therapy when we start Erenimab until the patient is getting good result.
Can it be given to pregnant women and breastfeeding, Dr. Areen?
No, until now, it is not approved to use in a pregnant woman. And so we do not advise it.
Agree.
Yes, we do not advise it. I mean, there are some of the older drugs that we are using during pregnancy for acute or for preventative therapy. And so we have to treat the patient based on case-by-case basis.
Can coffee trigger migraine, Dr. Rody?
Sorry, doctor, can you repeat the question, please?
Can coffee trigger migraine?
Yeah, sometimes, especially when patients are stopping coffee, can directly trigger for them migraine, or the excess of coffee can also trigger migraine on both sides.
Coffee is the medicine to treat migraine, because if you see in migraine or Panadol Extra, it contains caffeine. But excessive use, of course, could cause so-called medication overuse headache. Is there something called vestibular, or can it be used in vestibular migraine? Dr. Areen?
Well, by definition, vestibular migraine patients are patients who have these vestibular symptoms, but at least half of their symptoms, they occur in patients who have migraine headaches. So these are patients who have migraine headaches, and at least 50% of their vestibular migraine attacks, or so the vestibular symptoms. So technically, it can be used in patients with vestibular migraine, because these patients should have history of migraine headaches anyway.
Okay. I'm not going to repeat some of the questions which you guys already answered in the talk. I think we covered most of the questions. Can we give valproate in case 2, Dr. Rody?
Depakine or valproic acid, it can be one of the treatment for migraine. It's one of the possibility. Despite she tried many medication, it can be one of the possibility. It's not a bad choice to give also Depakine or valproic acid.
So last question for Dr. Areen. Can we give Erenima for cervicogenic headache?
It's not indicated for that particular diagnosis.
Yeah, but if it's cervicogenic headache due to migraine, then possibly it's a good idea to give it.
I mean, so 70% of patients with migraine can complain of neck pain. So if their neck pain is related to migraine, then yes. But if it is purely cervicogenic headache related to cervical degenerative disc disease, it would not be indicated.
Exactly. Okay. So hereby I conclude the meeting. Thanks, Dr. Areen. Thanks, Dr. Rody. Thank you, Novartis and MCO, for allowing us to be members of this meeting. We promise you for sure in the future to have more headache cases and headache chapter meetings. And thank you very much for all who are attending this meeting. And thanks a lot. Good. Have a nice day.
Thank you. Thank you. Thank you all.